For my conflict of interest disclosure slide, I do receive an honorarium with Hoggerberry Publishing Group for my work with the Clinical Handbook of Psychotropic Drugs. The latest edition is 24th edition, and I will mitigate any potential bias. All the material presented here today are developed by myself. I will be presenting, again, mostly systematic review that will include both positive and negative trials, as well as some newer literature that hasn't been included in systematic reviews. I'll mostly be using generic names for the medicines, and all recommendations will follow national and international guidelines to the best it can. Depot antipsychotics is an area that has a lot of off-label prescribing, so we'll touch on some of that. So for the learning objectives, by the end of the sessions, I hope that everyone will be able to recall some commonly available, safe, and effective depot antipsychotic injections. We will be able to identify patients who may benefit from depot antipsychotic medications, and we'll discuss that as far as the benefits seen in some of the evidence as regard to long-acting injectables. I will compare the side effects briefly around depot antipsychotics to its oral medications. And then we will spend some time talking about pharmacokinetic principles that I think are relevant to our practical use of long-acting injectables as in regards to dosing, switching, and different clinical scenarios. So, I think when we talk about depot antipsychotics, one of the first things that comes to our mind is medication adherence. Right? Medication adherence, the FDA defines it as how closely a patient takes the medication as prescribed by their physicians. When we think of full adherence, it's not actually 100%. In the literature, full adherence is typically described as 70 to 80% adherence. And in certain things like HIV or hepatitis C, it might be closer to 90% adherence as full adherence. And what that relates to for if you're taking 80% of your meds, it's really taking 6 days of medications every week, pretty much. So even in the literature, they kind of have some leeway that not everyone takes all their meds. And non-adherence is very common, not just in psychiatric conditions. It's common in things like diabetes. It's common for things like post-heart attacks, and it's common in infectious disease like HIV. For schizophrenia, what we're focusing on, the prevalence of medication non-adherence is estimated to be around 40%. So we're going to start with getting people engaged. So for the most part, we identify patients who may or may not be adherents using our own judgment, using clinician judgment. And that has been studied by 2 studies in Dallas some time ago. So the 2 studies, they use something called the medication event monitoring system, or the MANS CAP system. So you can see it here. It's kind of a device on top of the pill bottle. And when you open the pill bottle, it registers that. So assuming that when they open their pill bottle, they are taking their meds, not just throwing them away. But if you don't open the pill bottle, then they assume they're not taking their meds. So in those 2 studies, they were small studies, but 2 studies, they found that non-adherence, so less than 80% adherence, were found around 50 to 60% of the participants in this study. So I guess I'm not going to ask it in polling or anything, just to kind of have a number in your mind. So how many of these do you think the clinicians were able to identify without this MANS CAP information? Okay. So the first study, none of them. The clinicians could not identify any of them. Okay, so with that in mind, what did they find in the second study, where they're trying to validate this finding? 7%, right? And I think that really speaks to our challenges as prescribers. We don't really know what people do with the medicine or that we dispense, right? We hope they're taking it, and our judgment of that is not sometimes the best thing to tell. And these are real-world consequences, right? Non-adherence leads to, if you're not taking your meds, your symptoms are not going to get any better. So you have persistent symptoms that affects patients' functioning, quality of life, leads to further symptoms like self-neglect, self-harm, maybe aggression, maybe using substances to really alleviate some of the symptoms and other vulnerabilities associated with that. If your symptoms are controlled and you become non-adherent, that leads to relapse. And relapse leads to increased hospitalization, outpatient appointments, or crisis management. And one of the risks is too is if we are not able to recognize non-adherence, that leads to unnecessary medication changes, and it's oftentimes incorrect diagnosis of treatment resistance. There are some studies that do look at how adherence affects hospital admissions and discharge. There was a study out of Austria, a group that's very interested in therapeutic drug monitoring. They looked at 161 consecutive admissions to acute psychiatry, and they found that 52% of them had lower than expected drug levels. So that can either mean one of two things. One is they have genetic changes that make them metabolize medicine faster. The other explanation for that is they're not taking the medicine as prescribed. So when they present, they have lower than expected drug levels. And then they follow the other end. There's another study that followed the other end on discharge, that 110 patients on discharge. This is out of Spain. They followed them up for 6 months, and they found that by 6 months, 56% of them had non-adherence to antipsychotics, less than 80% adherence. So it is highly prevalent, and certainly in my practice in tertiary, almost every patient that comes through tertiary system has a history of non-adherence to an extent. And that's due to various reasons. So very complicated, a very complex issue. There's been increasing interest in recent years to see whether or not these non-adherence or relapse will lead to changes in treatment response. So this is a study out of the Toronto First Episode Psychosis Program out of CAMH. It is a retrospective study. One of the lead authors actually is Dr. Over Geet. They looked at 130 patients through the chart review who were able to achieve positive symptom remission. So a remission in their positive symptoms in their first episode when they present. But then they relapsed due to non-adherence. That's their inclusion criteria. And they found 130 patients in their program like that. And they looked at the second treatment episode to see what's different. What they found in this graph here, that you can see, is that in the first episode, they have a much more rapid improvement in their positive symptoms as compared to the second episode, right? Another thing to note is they followed them for almost a year. Is that the second episode around, less than 50% of these patients achieved positive symptom remission. Okay, and then the program actually have a strict treatment protocol. For the most part, these patients were on the same medicine for the second episode, except they're on higher doses. And despite that, they're not really achieving the same symptom remission they did the first time around. So hopefully more studies will come out and to see if this is a true finding too in other areas. So there's a lot of focus in improving medication adherence, and fortunately, not a lot of them are being studied robustly with a lot of evidence backing to it. But I think in practice, there are certain good principles that we as a pharmacist try to follow. One is we always try to simplify medication regimen, right? We want to look for once daily dosing. We know that in other areas of medicine, anything that's dosed more than once daily, the adherence tends to go down. We want to reduce pill burden whenever possible. Right? Hopefully, they're not opening their bottles and they're getting a handful of pills. That visually deters them to take the meds. Whenever possible, if medicines are ineffective or no longer necessary, we can deprescribe. Discussing and addressing side effects is important, and that's in various literature. I always say talk about side effects and addressing the side effects with the patients. And if possible, you can reduce the dose and to alleviate some of the side effects, or for certain side effects, you can add other medicines like anticholinergics for EPS to alleviate some of the side effects, at least in the short term. And then there's also use of alternate formulations like liquid formulations or dissolving tabs that might help with adherence. And for the purpose of our talk and why we're here is to talk about the use of long-acting injectable antipsychotics, right? Whether or not these depot antipsychotics, what is their role? And there's been a lot of proposed rationales for the use of depot antipsychotics. And there are a lot of advantages that the experts seem to believe in. In one of the big one is able to overcome partial or poor adherence, right? Once the injection is in, then you know the medicines will be in them and they'll be released. And the other advantage is it really eliminates a around adherence. So if someone was to relapse or the symptoms get worse and they were on the depot antipsychotics, then you're not really guessing whether or not they took their oral meds. So it helps with that. It does eliminate daily administration of meds or cut down some of the pill burden they have. Some of the newer antipsychotic injections have less fluctuation in the drug levels compared to the oral, so less peak to trough fluctuation, so that it gives you a more consistent drug level. There are client preferences. People who prefer depot antipsychotics because they're more discreet, is given less frequently, so to them it might be more convenient. It promotes regular contact with the healthcare team because if you're an injection that has to be every 2 weeks, every 4 weeks, then you're showing up more frequently for those injections. There are studies to show that physicians and clients have improved satisfaction when they transition to depot antipsychotics, which is I was surprised when I saw some of those studies. We will talk a lot about the evidence around relapse and hospitalization, but it is one of the big rationale or proposed benefits of depot is it might help reduce relapse. There are disadvantages to depot antipsychotics that we need to address. It's tougher to titrate depot antipsychotics, and the dose titration can take months to get to a dose. And once you're on a depot antipsychotics, there's much less flexibility in dose adjustment, right? It takes time for that to happen. The injection has pain associated with it, so the pain in injection sites or needle phobia can really deter patients. One of the big one is stigma and mistrust to the patient, and oftentimes what I hear about is, why do I need to be? I'm taking my oral meds. Why do I need to be on depot antipsychotics? Don't you trust me? I'll take my meds. And in there, I try to say, well, it's not about trust, right? This is something we do standard, and the evidence suggests it might help. And we'll go for some of the evidence to help with some of those dialogues. Depot antipsychotics do need to be stored in a certain way, and some of them need to be reconstituted, so that's an added step. There are more frequent travel, either if our ACT teams are going to give them depot antipsychotics, or the patient has to come to a clinic, so that does have travel time. And one of the concern is, since it acts longer, if they have side effects, the side effects will last longer, and then we will talk about that too. Okay, so let's jump into some of the evidence part here, and then see what some of the major guidelines say about depot antipsychotics. So our Canadian schizophrenia guidelines say that patients should be given the option of oral or depot antipsychotic. That's in line with their preference. So that's they call it a good practice point. So we should offer it and see what the patients decide. The APA guideline published last year has a suggestion that suggests with moderate confidence that patients should receive treatment with a long-acting injectable antipsychotics if they, again, prefer it, but they have an added thing, whereas if they have a history of poor or uncertain adherence, so not just patient preference, but if they have a history of poor adherence, then this is something to consider. The British Association of Psychopharmacology have some similar recommendation from last year too, is patients should be offered the option of depot antipsychotics for maintenance treatment, given that they have a lower evidence of relapse, a lower risk of relapse. When I see the guidelines recommendation, what things struck me is that they're not very strong. They're not saying everyone should be offered. They should be given the option. If they have poor adherence, then we suggest you offer it to them or use that. And that has to do with the evidence base behind it. And we'll go through some of the evidence base behind it. And there's a similar slide I presented for the clozapine session, that there are cautionary tales in some of the psychopharmacological evidence. Typically in medicine, RCTs or randomized controlled trials are the gold standards for showing cause and effect and showing a medication work, because RCTs are better able to control for confounder and biases. However, in psychiatric research, that's an issue because it's prone to sampling bias. So the patients that are in RCTs often don't actually reflect those that are in our practice. So we then relied a lot in observational studies. So that's cohort studies, case control studies, and in the case of depot antipsychotics, what we see a lot of is pre and post studies, or what we call mirror image studies. So essentially, you're taking the same patient that were on oral antipsychotics assume, and they had a risk of relapse. And then you look at that same risk of relapse when they get switched to a depot antipsychotics and see if their risk is lower. So we'll see a lot of data from that. And the advantages of observational studies, it reflects real practice because it encompasses all patients in care generally. However, it is prone to bias and confounding. So selection bias, confounding variables like substance use can play a part in some of the outcomes. So it's less able to show cause and effect and really describe just a relationship in the factor and association in the factors. So with that in mind, let's go to some of the evidence. So there's what I call evidence-based confusion in the RCT literature, and that leads to the guideline not having a stronger recommendation. So the story started 10 years ago when Lloyd and colleagues published a meta-analysis with 1,700 patients. And in that meta-analysis, they found that depot antipsychotic drugs reduced relapse rates of outpatients from 33% to 21%. So a number needed to treat, they say about 10. However, in 2014, Kishimoto and colleagues did a larger meta-analysis with some newer evidence encompassing more second-generation antipsychotics. They found that the pooled LAIs were not superior to oral antipsychotics. And this finding has since been replicated by Ostruzzi and colleagues in 2017, a similar size study. And again, they found no robust evidence to support a better tolerability or efficacy of long-acting injectables, with the exception of aripiprazole in their study that found a small benefit. So because of that, of the inconsistency in the RCT evidence, it's hard for the guidelines to make a strong recommendations. In the observational literature, though, there are benefits seen. So this is pretty much the same slide I presented for clozapine. It's again the Swedish observational study with 30,000 patients, a follow-up of 7 years. At that time, I presented it. The oral clozapine show lower risk of psychiatric hospitalization compared to no treatments, and it's amongst the top agents, despite clozapine being given to treatment-refractory patients. Some of you might have noticed amongst the tops, all the other agents are depot antipsychotics, right? So, and this also have a conservative bias to it because depot antipsychotics are typically given to patients who are more non-adherent, so may have higher risk of relapse and rehospitalization. And despite that, the depot performs on the top compared to a lot of the oral antipsychotics. From the same database study, they published another study a year later looking at mortality risk. And there, too, they found a 33% risk reduction in death, comparing long-acting injectables to oral equivalent. So as you can see on the top here, the depots perform better than the orals. They estimate that there will be 2 to 4 fewer deaths if 100 patients were treated on this for 6 years. So it does need, it's a small effect, and they have to be treated for a long time. And unlike the clozapine literature, this hasn't been replicated worldwide as much. I think last year, a couple months ago, a Taiwanese study published, and they also found the benefits for mortality risk reduction with depot antipsychotic. But it'd be nice to see some North American literature or other parts of the world. So given all that confusion, there was a new meta-analysis done, systematic review done, that was published a few months ago by Kishimoto and colleagues and John Kane, Christoph Corello of New York. They have an ambitious study design where essentially it's 3 studies in one. They want to do a systematic review that looked at all the RCTs, all the cohort studies, and all the mirror image or pre-post studies. So we're going to go through it as if it's 3 separate studies, because when you read the manuscript, it does look like that. So on the RCT arms, they had 32 studies with about 8,500 patients, about 62-week in duration, and there are intermediate to high risk of bias in the studies. About most of the studies are single-blinded or open-label. Some have selective outcome reporting issues. Most of the studies are funded by industry. The participants are on average 37 years old, and about a third of them are female. Most of the intervention studies are second-generation depot antipsychotics compared to their oral counterpart, to a lesser extent first-generation depots to first-generation oral medicines. Then looking at the observational literature, it has the largest evidence base with 65 studies, 30, almost 400,000 patients. Most of them are retrospective, again, about a year and a half in duration, and again, mostly funded by industry, about half funded by industry. Participants are 41 years old, 44% of them are female. The interventions are a bit more mixed, but still the most common intervention is the second generation depot compared to second generation oral antipsychotics. And then there's a mix of depot compared to mixed orals being used. And the last study, systematic review they did was the mirror image design, where there's 40 studies, about 12,000 patients. Again, mostly retrospective. And the patient group is very similar to the cohort study. What's interesting with the mirror image study is half of the studies did not report the intervention. So a lot of these studies just kind of say they were on oral and then get switched to depot when we looked at the risk, but they don't really go down to what oral medicine they were on and what depot medicine they got put on. And for the outcome of the systematic review, they were focused on hospitalization data. And if they can't find that, they will try to use data from relapse data. So what did they find? So if 100 patients are started on antipsychotic depots instead of oral, and they were on it for about a year and a half, based on RCT data, it looks like there might be 2 fewer hospitalization or relapse. Okay, based on cohort studies, there may be 3 fewer hospitalization or relapse. And if you're basing it on mirror image study, the effect's much larger, 25 fewer hospitalization or relapse. So what the authors say that's important here is that unlike the other meta-analysis, what they did find is a consistent, statistically significant benefits across the 3 study design that show RCT, the depot has a benefit over oral antipsychotics in terms of relapse or hospitalization risk, right? Even though it might be small, the benefits. However, they all have different limitations to them. So again, as I mentioned, the RCTs have a lot of sampling bias. So patients who are non-adherents are generally not enrolled in RCTs. So you underestimate the benefit there. Cohort design have a conservative bias too, making the numbers smaller. It's depots are given to the people who are non-adherents. So then it's harder to show a benefit in that case. And then in mirror image study, they might be exaggerating the actual effect because there's an expectation bias when you switch from one intervention to another, you kind of expect things to get better. So that might have played into the data there. So reading the manuscript, it sounds like the impression is maybe the true effect is somewhere between these two, but we don't really know. It looks like there's a consistent benefit though. So one of the big questions is, are there subgroups of patients that might benefit more from depot antipsychotics? And that's important, right, as we identify patients. So inherently, we're looking for patients who may have a history of non-adherence or partial adherence to oral antipsychotics. So that makes sense, even though the literature doesn't really have that as an inclusion criteria. I think relevant to us, in our population, we're treating high prevalence people with concurrent disorder. And it makes sense people with substance use have a harder time to stay adherent to treatment medications. And so we do it. However, there's really not a lot of evidence, just like with anything with concurrent disorder, not a lot of evidence to support that practice yet. Where there's a lot of evidence starting to mount is in the field of early psychosis. So that's been an active area of research in the last few years. And actually, our local group from Dr. Barr and Dr. Honer has published a systematic review, I think 2 months ago, on this subject, comparing depot antipsychotics to oral antipsychotics in early psychosis. In that systematic review, they found no evidence of benefit in relapse rate, all-cause discontinuation, or adherence rates. They did find a statistical significant benefits in hospitalization rate in the RCT data, but wasn't shown in the observational data. And there's good reasons for that. There's not a lot of data. So when you look at the forest plots and stuff, there's a lot of imprecision and inconsistency in the data. Generally, their small sample size is too small to show any benefit, even if there is. So there's very low certainty. It's an area that needs more research, and that's coming because There's one more RCT that wasn't included in that systematic review, and that was published late last year around December by John Kane's group out of New York. And they call this study the PRELAPSE study, specific looking at long-acting injectable compared to usual care in early phase schizophrenia. And the PRELAPSE study design is quite interesting. So instead of randomizing by patients, they're randomizing by treatment sites or clinics that treat early patients with early phase schizophrenia. They had 39 clinics across 19 states in the US. It was an unblinded study, and they have 2-year follow-up, and the medicine was funded by the company. So breaking down to the two sides, there's clinician's choice arm, where the clinician can do treatment as usual, offer their practice, offer their treatments as they usually do. And then there's the depot sites, which they are using aripiprazole monthly depots, and they have 19 sites there. And what's relevant with this study that I thought was really relevant to top was, it's not just the intervention that's different, the sites got different training. Okay, the treatment as usual site just got 1-day training about the study and the details of the study, whereas the depot sites got 2-day training. And it's things we're talking about now. So role of non-adherence and relapse, how effective are depot antipsychotics, what the reasons for using depot antipsychotics, how we're going to discuss with family and patients, and guideline to prescribing depot antipsychotics. So a lot of similarity in education as we're going through. And overall, the participants in this study are 25-year-old, a quarter of them are female. As far as race, 44% identify themselves as Black, 35% of them identify themselves as white, 2/3 of them live with family. As far as antipsychotics use, the mean duration of antipsychotic use is around 630 days, so less than 2 years. And it's interestingly, about 46% had less than 1 year of antipsychotics use. Despite the study is being called PRELAPSE, the mean number of hospitalization was 3. So many of them have already had some hospitalization. The intervention, as far as what the people prescribe, it's not clear. They don't really say a lot. In the treatment as usual arm, they don't really say what people got put on. They just said that 42% of them received some sort of depot antipsychotics before the hospitalization, because they don't actually limit the treatment. They could get depot if they want. Compared to the aripiprazole monthly sites, at 91% of these participants had at least one depot injection. And they say that as a success, but I will caution that, because they pretty much excluded 250 patients right off the bat at this site. So the actual acceptance rate of depot is probably lower in real practice. And what did they find? So even in this early phase illness, they found that per 100 patients treated at these aripiprazole monthly sites, there will be 14 fewer hospitalizations, a first hospitalization in about 1.5 years. So I have the absolute number here. They also found that these depot sites delay time to first hospitalization by about 80 days. So 600 days compared to about 530 days, which could be significant. As far as symptom scores and quality of life, they were not able to show any difference between the two sites. So overall, there seems to be some benefits in the hospitalization. Okay, so in summary, what does the evidence show? And then what do I tell people when I tell them about depot? Well, it looks like the evidence do suggest that the depot antipsychotics reduce hospitalization risk more so than their oral counterpart. And one of the big selling points that I work in tertiary is I try to tell people is, it'd be nice if you don't come back to the hospital for a while, right? Because you want to go out there and do your thing. So they're generally okay with that. In outpatients, it might be a little trickier. And the patients that might benefit most is people having difficulty with medicine, so maybe having discussions around adherence, and especially early course in the illness. Okay, it's never too early to think about a depot antipsychotics. And depot antipsychotics may also reduce the risk for mortality, and then it'd be nice to see further evidence to confirm some of those findings.
So, Jackie, if you want to pause for a second, you've gone over a lot of evidence information, and let's just see if any questions are coming up.
Sounds good.
You can speak, or you can put it in the chat if you prefer, but we'd love to see your face and hear your voice if you're willing. One thought I have is, that's a lot of numbers, a lot of technical information. How do you translate that into a conversation with a patient?
Yeah, and I think the important thing, I think the evidence, even though the guidelines have kind of softer recommendation, is in the real world, it does seem to reduce the risk of relapse, and it makes taking medications easier. And it might be inconvenient at the start to have to go to clinic and do it, but I always tell people to just try it out and see how you like it. And if it works for you and you get used to the habit, you might find yourself like it a lot. And that seems to happen to in the literature. People, the satisfaction still go up over time. So yeah, and sometimes it is a tough sell, and you have to play the bad cop and say, look, you haven't been taking your medicine. That's why you're here. And we've been checking your drug levels. There's nothing there. And that's kind of peculiar. And so to show us that you're going to follow the treatment, and this only works for certified patients, we're going to give you a deeper antipsychotics and see how things go. So it depends on the scenario. Kind of play good cop, bad cop a little bit.
Yeah. Dr. Mickey has a question here. How does the adherence data, I guess, related to antipsychotics overall, compare to other areas of medicine like hypertension, diabetes, or HIV?
Yeah, that's a great question. And most of the adherence literature actually is in cardiovascular disease, and that's where a lot of the interventions to improve adherence are kind of geared where they want to study, because that's a huge issue with them. And our numbers are kind of comparable to them, but I will say the psychiatric evidence base is not as big as the cardiovascular evidence base, right? And where I find is the part that's particularly missing, especially in our practice, is most of these don't include people with concurrent disorder, right? So we say 40% for schizophrenia in general, but those are not people with concurrent stimulant use disorder or opioid use disorder. And I feel like anecdotally, our local area practice can contribute to that, because I feel like our numbers are probably much higher if they have concurrent disorder. So, but in broadly speaking, for schizophrenia, it seems similar to cardiovascular medicine. Yeah.
Related to that issue, in the prelapse study, I presume they screened out people with concurrent substance use?
I can't remember if they did or not, but I think there was over a low amount. I can take a look at that and reply to that after. Yeah, sending out the listserv. Yeah.
Let's see. Sorry, one more question, and then we can move on. Are there other areas of medicine where we can compare LAIs to oral meds? So,
yeah. I think the other one that we're spending a lot of time on is the buprenorphine long-acting depot. That's gained a lot of interest compared to the oral buprenorphine naloxone products, and unfortunately, their evidence is nil and it's not quite there yet to show. And I think in the next year or two, hopefully we'll have some local data to present to see what the adherence rates or the relapse overdose rates look like compared to those. Especially the other areas of medicine, I'm not aware of any other areas of medicine where depot is used as much.
The only thing that occurs to me would be something like insulin pumps. I don't know. That's not a perfect comparison, though.
Yeah, and it's different because I think they highly screen out who's going to get it and such too. So not in the same sense as schizophrenia for sure. Yeah, that I'm aware of. Maybe there's other. Yeah. Cool. Let's jump into some of the safety, and then we'll fly through that, because I think this part's smaller, and then we'll talk about some of the practical things too. So one of the big things about safety to remember is it doesn't depend on the formulation. Oral tablet or dissolving tab or liquid or the injectable has the same active pharmaceutical ingredient in there, right? So risperidone tablet is the same as risperidone depot in terms of the active ingredient. So because of that, for the side effects part, it really is similar to what the oral medications are. And this is a table taken out of the latest APA guideline where they compare some of the side effects rates using pluses again. So if you're using something like risperidone, you're more likely to see EPS and hyperprolactinemia as compared to if you're using something like aripiprazole and stuff. The downside of the APA guidelines, they don't have suclopenthixol or flupenthixol shown there, so it's hard to extrapolate there. And these are some of the stuff that also look at some metabolic side effects and such. So, okay, so since they have the same ingredient, we can expect some of the same side effects. However, depot antipsychotics do have additional concern. So one of the concern is the concern for allergy. And so most depot guidelines will always say to ensure oral tolerability, at least a few doses of their oral medicine to make sure they're not allergic to the pharmaceutical ingredient before you inject it to them. There are some concern around the oil used in the first generation depot, and I couldn't find any reported cases of allergy as a result of it, and I couldn't find any incidents that how common it is. So, but it is concern that some people have. It seems really rare though. More commonly that's noted is the local injection site reaction. We'll talk a little bit about that. Perhaps the bigger thing to realize is depot antipsychotics have a delayed side effects because of the delay release. So especially for first generation depot, their monograph really cautioned that you need to give test dose or lower doses to make sure they don't develop EPS. They can tolerate first generation antipsychotics. And with the atypical antipsychotic depot, they all just say you have to ensure they can tolerate the oral medicines before you transition, kind of thing. So just make sure they can tolerate the medicines. And when we adjust those, we want to make sure you achieve steady state of 3 to 5 half-lives, and we'll go over what that means. Now, the large systematic review did look at side effects as one of its outcomes, like many outcomes. So I always say that these are more signals, because you can tell they ran a lot of analysis trying to see if there's any signals of differences in side effects. And the reassuring thing is, for the most part, there were no difference in side effects, like serious adverse effects, EPS, or metabolic changes. What I found interesting was that the LAI had less somnolence, perhaps because it has more steady drug levels. And then oral antipsychotics are better for anxiety, maybe because it has more fluctuations. So people the sedation effects, maybe anti-anxiety effect as well. The LAI seems to have better for suicide ideations, and oral antipsychotics are better for tardive dyskinesia. So which I find interesting, and would like to see hopefully other studies can look at that. One easy explanation is maybe the people were not taking their oral antipsychotics, so you're not going to develop the chronic long-term side effects if you're not really adhering to the medicine as much as depot does. So, as far as local injection site reaction, it's really variable incidence depending on mostly injection site techniques, also the injection volume and the composition of the depot, the formulation of the depot. So common reactions are pain, obviously, but there can be redness, bleeding, and swelling. One point to note is that we generally advise to avoid the dorsal gluteal route for risk of sciatic nerve injury to minimize that risk. One of the bigger concern people have had is the risk of neuroleptic malignant syndrome, right? Serious consequences of antipsychotic use. And the concern is giving depot antipsychotics with such long duration of action will worsen NMS outcomes. So there was a recent review that was done to look at this, and there were 662 published cases of NMS that were reviewed. They were specifically comparing depot antipsychotics to oral antipsychotics and see if there were any difference. So there were no difference in the way the symptoms are presenting. EPS, hyperthermia, autonomic disturbances, and altered consciousness are still the most common sign of NMS. Reassuringly, 86% of the NMS cases recovered completely, so that's great. And there was no difference between oral and depot antipsychotics. There was no difference in the duration of hospitalization as a result of NMS. Where there is a difference is the symptoms of NMS do last longer, about 4 days longer in depot cases compared to oral cases. So overall, I feel like any patient outcome seems comparable. Okay, and that's it. And so I'm going to spend the last bit of time talking about some practical consideration of with depot antipsychotics, and I'm going to dive into that with a lot of pharmacokinetics, so it might be a lot of jargon, and feel free to ask for clarification. So in Canada, we have 6 depot antipsychotics available. So 3 of them are typical antipsychotic or first-generation antipsychotics. So we have fluphenixol, haloperidol, and succinylpenfixol. For atypical antipsychotics, we have aripiprazole, paliperidone, both as a 1-monthly formulation and a 3-monthly formulation, and risperidone. So, and risperidone and paliperidone are related. So to a lot of people, we only have 5 depot antipsychotics available. Not available in Canada are pipotidine and fluphenazine, which have been discontinued by the manufacturer. Fluphenazine is only available in some Nordic countries, so don't have access to that. In the US, they have more options. So they have a olanzapine depot in the US, they have a second aripiprazole depot, and the FDA just approved the 6-monthly paliperidone depot. So hopefully they will submit to Health Canada, and we hopefully will get it next. That'd be quite interesting to see. So this table, I'm breaking it down to first-generation depots on the top, and then the atypical antipsychotic depots closer to the bottom. And so looking at the approved sites, so for the first-generation depot, the approved sites primarily that we use is the gluteus site. So fluphenixol and succinylpenfixol are approved to be given to the 5, but that's done less commonly. One thing to note is here is it's not approved to be given through the deltoid muscle. Okay, it has never been studied that way. I know a lot of patients prefer it, and it's done routinely and anecdotally seems to have great tolerability, which just never been studied, and so they don't have Health Canada labeling for that. For atypical antipsychotics depot, they are all studied for both deltoid and gluteus administrations. As far as dosage strength and volume for the first generation depot, it really depends on the dose that is being given. For aripiprazole, it's anywhere from 1.5 to 1.9 mil. Paliperidone 1 monthly can go up to 1.5 mil if you're using the biggest dose. The 3-monthly formulation goes to 2.6 mil if you're using the biggest dose. Risperidone is always 2 mils with the diluent that's used. Of the depots, aripiprazole and risperidone are the ones that needs to be reconstituted, and risperidone is the only one that needs to be refrigerated between 2 to 8 degrees, and pretty much all of them needs to be protected from light, even some of them don't say it. Now, an important thing to note is pharmacare does require special authority for the atypical antipsychotic depots. Okay, so they will cover the first generation depot, but they won't cover the atypical depot unless you apply for special authority. And the criteria is if they have persistent symptoms despite multiple oral antipsychotic trials, if they had side effects to a first generation depot, side effects like EPS or tardive dyskinesia, or they are non-adherent to oral medicine, resulting in sequelae like hospitalization. So then they will cover the depot antipsychotics. This is a table of what the usual doses are. And for the most part, the dosing intervals is every 2 to 4 weeks for most of the depots, and paliperidone has a 3-monthly injections here. We'll go over more about some of the loading doses. So a brief thing about how the depot antipsychotics work. So the way the pharmaceutical company formulate it, so the first generation depot are formulated in oil. Okay, so essentially when you inject the medicine suspended in oil, it goes into the muscle, and over time, the oil gets broken down and the medication kind of dissipate out, so and then gets released into the systemic circulation. So, in some of the literature, they do say that this is a bit more of erratic absorption and it's less predictable. With the newer depot formulations, the atypical antipsychotic depot formulations, they use different technology that's shown in the middle row here. They have different particle size. So aripiprazole and paliperidone uses this technology. So different particle size of drugs that get, once injected, gets broken down, and so they get released at different time frames. Risperidone has the medication in a microsphere. Once injected, then takes weeks for the microsphere to hydrate and then eventually release the medicine. So they just have different technology to release the medicine. And partly because of these technology, it's very hard for companies to just pick up the drug and say, I'm going to make a generic of it. So now, what the formulation change really does is it affects the pharmacokinetics of the drugs. So pharmacokinetics is the study of what happens when you take a drug and how it travels through your body. Right? Broadly speaking, it's usually broken down into the absorption, distribution, metabolism, and elimination of the drug. So we're going to go through some of these concepts. So again, pharmacokinetics, how the drug travels through the body. Another related thing is something called pharmacodynamics, and you might have heard of. That is the study of what the drug does to certain receptors to elicit a pharmacological response. So we often think of things like if you have increased concentration, it will engage the receptor more and get a bigger pharmacological response. And that's really true for things like respiratory depression with opioids, that happens. But for most medicine, what is more true is probably a sigmoidal-like curve, where you build up the concentration, and after a certain concentration, you get an increased likelihood of response. And after a certain point, your response curve kind of plateaus, so you can keep pumping in more and more higher concentration of drugs, but you don't get more response. Instead, you get more and more toxicity starts to happen. So that's pharmacodynamics. And we'll be focusing on pharmacokinetics for deep antipsychotics. So looking at pharmacokinetic studies, one of the things that often show up is something called a concentration to time curve. So a concentration to time curve has concentration on the y-axis and time on the x-axis. And so what essentially happens is someone takes the medicine, could be oral, could be IV, could be IM, and then it gets absorbed through the body, so the concentration starts to build. And once it's absorbed, then it gets eliminated in the body, and the curve and the concentration goes down. Looking at this, the key two things to look at for that is one, the Cmax, what the peak is. So it gets to this concentration, that's the peak concentration. Presumably that's hopefully within a therapeutic range that will have an effect. But more importantly for us is the Tmax, the time to maximum concentration. And that's the time you expect to see most effects or most drug in the serum. So we will be using the term Tmax a lot. It'll keep coming up. So this is a concentration time curve for clozapine. So after an oral administration of clozapine, you get an absorption, gets to the peak around 210 nanograms per mil. And more importantly, that seems to happen around 2.3 hours, right? And that's kind of where we expect. If we were watching for tachycardia or sedation, we would kind of expect that around the 2-hour mark. Another way to visualize what's actually happening to the drug is during the initial phase, it's being absorbed, then it's being distributed to all your tissues, and then after all that's done, it's being eliminated, right? So another big thing is to look at the elimination curve, which ties into our next big thing we talk about is something called half-life. Half-life is generally spoken of as the time for 50% of the drug to be removed. Okay, and it's a consistent number. It's a percentage of the drug to be removed. So let's look at this concentration to time curve. So going from 100 to 50, 50% of the drug is removed, and that took 2 hours. So for the next 50% of the drug to be removed, going from 50 to 25, that's another 2 hours, and then it will just go on like that. And most drugs that through this half-life is either eliminated by liver metabolism or renal elimination. Closely related to the concept of half-life is something called steady state that I've alluded to. And that's essentially having a consistent drug concentration that has been achieved. So if you look at someone taking a medicine on a continuous basis, at the beginning, they're really building up their concentration over time. So each time they take the medicine, they climb up a little more until to the point where they keep taking the medicine and a consistent amount is in a kind of ballpark. It's not the same number every time. It depends on what time frame it is, but a consistent amount has been achieved. And that's typically achieve around 3 to 5 half-lives. And an easy way kind of to remember is generally that's around 3 to 5 dosing interval. So if a medicine is given once a day, you kind of expect the steady state to be achieved around 3 to 5 days, because generally the dosing interval matches the half-life to an instance. So putting it together, I know I went through that pretty fast, so hopefully I didn't lose a lot of you. For an oral medicine, when the oral medication is being absorbed, that will dictate some of the onset of action, the peak action, and the Tmax, right, time to peak action. And then looking at the other end, the elimination phases, that would dictate the drug's half-life, so how long the drug will work after a single dose, and how frequently then you have to administer those. So let's look at an example like loxapine. Loxapine is a tablet that generally absorbs pretty quickly, and so it achieves the Tmax for 1 to 2 hours. So if you were using loxapine for acute agitation, you'll be watching for those peak effects in 1 to 2 hours. So resolution or reduction in the agitation. Loxapine has a half-life above 3 hours, but really a wide range, 1 to 14 hours. And because of that, it's generally given 2 to 4 times a day. Okay. One thing to note here is for most medicines, the elimination time, the half-life, is longer than the absorption time. Again, that's true with most medicines, with the exception of depot antipsychotics. Depot antipsychotics have something called a flip-flop kinetics, where because there's a barrier to absorption, the absorption rate is slower than the elimination rate. In essence, what ends up happening with depot medicines is that the absorption dictates both your Tmax, the time for the max action, and your half-life, right? So the absorption is king here. And depending on the formulation, the release is very, very, very different. So it could be hours to days to weeks. They'll have a variable onset, and so they'll have a variable duration of action. And to illustrate this, I chose to present paliperidone pharmacokinetics. So if you're taking paliperidone oral, which is also kind of controlled capsule, its Tmax is 1 day. Its half-life is 23 hours. Its time to steady state, so it's around 5 days, 5 dosing intervals, and it's still eliminated renally. And you're giving the same pharmaceutical ingredient in the depot format, all of a sudden the Tmax is 13 days, half-life is 25 to 49 days, and it takes 2 to 3 months, and some would argue maybe up to 4 months for it to get to steady states, and it's still eliminated renally. And it's not the paliperidone has changed, it's the way the release from the depot that affects a lot of these pharmacokinetic parameters. Another extreme example to be aware of is risperidone. That's in the microsphere. And this one is the oddest one of them all, because after you inject the risperidone depot, for 3 weeks, nothing happens. The drug doesn't get released. The microsphere is just getting hydrated. And then after 3 weeks, then the drug gets released, and it gets released very quickly. And so your Tmax achieved in 30 days. And once it starts releasing, the half-life is 3 to 6 days. And generally the release is done by week 8. So risperidone has kind of a really different release kinetics. So again, going back to the table, looking at all the depot. So for the first generation depot, they're all formulated in an oil vehicle. So because of that, they have very similar pharmacokinetic parameters. The Tmax is anywhere from 3 to 10 days. Again, that speaks to that erratic absorption, that there is a huge window where these drugs is going to hit its Tmax, and it's going to be quite different. And so they need that oral overlap at the beginning to make sure you have consistent antipsychotic levels. And they all have similar half-life, or 3 weeks to finish. And time to steady state is 2 to 3 months, about 5 depot injections, right? Usually given every 2 to 4 weeks. Then with the atypical, because they have different formulation, there's a bit more variability in the kinetic parameters. So aripiprazole is Tmax is 4 to 7 days. They say you need a 2-week overlap, and it has a long half-life, 30 to 46 days. So really 3 to 4 months for steady state. Paliperidone 1 monthly, kind of went over. 13 days Tmax, 25 to 49 days. It's interesting, they say time to steady state are 2 to 3 months, even though its half-life is very similar to aripiprazole. So it might, for some patients, take up to 4 months to get to steady state. And then risperidone for that microsphere, its Tmax is 30 days, needs 3 weeks of overlap because nothing happens for 3 weeks after you give the depot. Now, one thing you might notice here is this little thing, that in aripiprazole, they have 2 different Tmax, deltoid and gluteal. And that's a concept that Dr. Rick Precision has published about and spoke extensively about this, is that the deltoid and gluteus administration affects the kinetics of the medicines. At rest, our body has more blood flow to the deltoid muscle. And so it leads to a faster absorption when things are given in the deltoid compared to gluteus. And Dr. Precision published a paper that looked at paliperidone specifically, and these are all based on their own manufacturer data. When you give paliperidone in the deltoid instead of gluteus, you get a 28% higher peak serum concentration. You get a shorter Tmax, so it reaches its peak concentration faster by 3 days. It has a shorter half-life, so the medicine gets released faster, so it lasts shorter. And all that encompasses that they have very different kinetics parameters. And if this was 2 generic medicine, and they have 2 kinetic parameters that different, they would not be interchangeable. They would be called not bioequivalent. And so the takeaway message is the injection sites can affect the kinetics of the medicine. Paliperidone is the one we know a bit more, and we don't know much about the first generation depot, right? Because they were never studied for deltoid administration. And so what I tell people is always try to be consistent with your chosen site, right? And if you were to change the site of administration, you can do that, but you do kind of have to monitor what happens. So if you were going from gluteus administration to deltoid administration because the patient asked for that, we should listen to them. But then we want to monitor for any peak dose side effects around the time of Tmax, whether they'll get more EPS. You also want to watch for where there's quicker wearing off effect. It has a shorter half-life. So before the next dosing interval, whether it's the kind of breakthrough symptoms start to happen, right, when you change the site. So it is something to kind of pay attention to. Okay, so we have kind of 5 minutes. And so what I'm going to do for the last 5 minutes is kind of run through traditional transition from oral to their depot antipsychotics based on the manufacturer monograph, okay? And for all the scenarios, it's for the coming month of October, and they're going to get their depot on October 1st. So paliperidone probably has kind of more straightforward transition. And so let's say someone was on 9 milligrams every day, and you transition in the depot on Friday, they come to the clinic, they get 150 milligram IM, which is their first loading dose. And for loading doses of paliperidone, they do tell you to give it deltoid because they want that faster absorption. And with that faster absorption, they don't need oral overlap, so they can stop their oral antipsychotics. They have to come back a week later for their second loading dose, this time 100 milligrams, again given on deltoid. And then after that, 4 weeks later, they come for their first maintenance dose. That they can give deltoid or gluteus, whatever the decision is. And there's a kind of approximate equivalent dose of 9 milligrams oral. It's roughly 100 milligrams IM. So that's the maintenance dose for that. So that's one straightforward. Risperidone is less straightforward because of the microsphere kinetics. So let's say they're on 4 milligrams risperidone, they will come get their first depot IM, 37.5 milligrams. And here the manufacturer doesn't say where to administer it, so anyone's choice. But then they have to continue taking their oral risperidone, all right, for the next few weeks. They can come in, even though 2 weeks later, they come for their second depot of risperidone. And this part is always kind of perplexing to me, is they come for the second depot, even though the first depot hasn't done anything yet because it hasn't released any medicine. That doesn't happen until after 3 weeks. Then they start to release medicine. So, and I think a thing to note here is even though the manufacturer says you can stop oral overlap at 3 weeks, the medicine then starts to release the days after that. So there might be a window where the level kind of drops quickly. So just kind of pay attention there to see whether or not you titrate down the dose at the end of 3 weeks very quickly or just stop abruptly. It depends what other medicine they're on. And the Tmax is from the first dose is expected at the end of the month. So quite a long leg. Aripiprazole, a bit more straightforward too. So let's say they're on oral aripiprazole and they get their 400 milligrams IM dose. The manufacturer suggests that you continue oral overlap for 2 weeks. And this is where some of the experts say might not be necessary for the full 2 weeks because the Tmax from the injection happens at day 5 to day 7 after the injection. So by that second week after the depot, if they're getting a lot of restlessness or akathisia, then you might decide to stop the oral overlap early, right? Because you know that the depot is starting to release already and it's already hit its peak. Aripiprazole recently got a labeling change. So the Health Canada approved a no oral overlap dosing regimen that's based on simulation data. So not a lot of patient experience with it yet. And so what they're proposing that you could do is you make sure they tolerate aripiprazole. That's key. They can tolerate it. There's no akathisia or other side effects related to it. And then what you can do is in the day of the depot administration, they get the oral aripiprazole 20 milligrams, and then they get 2 of the 400 milligrams IM depot. So it is based on the kinetics, it probably makes sense to give 1 deltoid and 1 gluteus, just kind of even out where the peaks are in the depot. And you can stop your oral antipsychotics then. And what from the kinetic simulation data is, it looks like they will get a lot higher exposure to aripiprazole weeks 2 to weeks 4 out compared to the traditional weighted doses. So until we know more, I would suggest that definitely monitor for akathisia and restlessness, right? Because you don't want to leave them with that because the chances of them coming back and continuing the depot is probably quite low after that. So something to pay attention to with this. Now, first generation depot is kind of trickier because the manufacturer has this vague comment that said you should continue oral antipsychotics, but at diminishing dose for the first week. But they don't really say how to do it. So let's say you're transitioning to sucralfate depot, then you might give the IM, and then for the next week, you're kind of not sure what to do, even though the Tmax could be happening. So I guess one simple way I always try to look at it is what tablets they have and what makes sense to them. So if they're on 50 milligram tablet or 2 or 25, then just half the tab for 25 milligrams for a couple of days, and then go down to 10 milligrams. You might need a new script, or you might quarter the 50 milligram tab or half the 25, and then at the end, you just try to quarter it, and just so that it kind of goes through, taper down. We don't really know a lot about what happens there. So, okay, last few things. Transitioning from paliperidone monthly to 3 monthly, you do need 4 months of stable paliperidone. And the reason for that is you want to make sure they're at steady state, right? So you're not changing dose for 4 months. You're already there stabilized, the side effects been addressed. Then you can transition to the 3 monthly injection, and the dose is roughly 3.5 times. The important thing to note of this is, most of you already probably know, is you have to shake the injection quite vigorously for 15 seconds to suspend the medication. And what happens is they suspect is when one of their studies they did is there were a lot of relapse 2 months after the depot, and they kind of account for that as they weren't shaken vigorously enough. And after you shake it, you have to give it within 5 minutes. So there is a bit more of an urgency to do it. There are a lot of combinations of switches from oral to depot. People can be on multiple meds. So one way to go through that is using online resource like SwitchRx, which goes through the kinetics of the different drugs. So that's I find always helpful. Or ask your pharmacist if your pharmacist is available. And if you're just transitioning from one depot to another and you know they can tolerate the new depot, for the most part, you can just start the new depot on the date the last depot is due. So that's kind of an easier way to look at it. And the kinetics usually work out. Okay, so in summary, I know I covered a lot of things, so apologies there. But some of the key takeaway message is that adherence affects outcome. outcomes like hospitalization and relapse. As far as guidelines, national and international guidelines do suggest depot antipsychotics for partial or poor adherence or patients who prefer depot antipsychotics. The evidence suggests that depot antipsychotics do reduce the risk of hospitalization, and there's especially in patients with early psychosis with the newer evidence. Overall, the safety of the depot antipsychotics is comparable to its oral formulation. And having some understanding of pharmacokinetics can help guide dosing and determining switch schedule around the use of depot antipsychotics. And for the most part, the manufacturer try to explain that best they can. And that's it. Thank you for listening, everyone.